Thank you very much for this nice introduction, Karen. Yes, I'm very honored to be here today and at this congress. And we have had a tendon workshop, which was very nice and with some nice attendance. And we have had some very nice discussion along the way. So hopefully we can have also some good discussions perhaps during and especially after my talk. As you can see, my title is a little changed. I would say I would go on with the modalities, the update tomorrow, which is the active part is today, and you could say the passive part of how to treat tendinopathy is tomorrow. But as you see this presentation, you can see why perhaps I have made this priority. So today I'm going to say something about how the contraction mode, does it really matter for how to treat tendinopathy really? And the short answer is really, it doesn't really matter. It's actually the load that matters, and maybe also the time under tension, which can give the results for the tendon and tendinopathy. And also I'm gonna give you a little add-on for the great talk of Karen about, I would say, load management and perhaps the whole idea of preventing tendinopathy. I'm gonna show you some data on that and how perhaps we can come around that in the future. So before I go on with my talk, I'll just acknowledge some people here who sort of have inspired me along the way and how I really came into research, and especially for most, I guess you know Peter Magnussen, Professor Peter Magnussen, who is the leader of the function and structure group at the Institute of Sports Medicine, and also in the Department of Physical Therapy, but also René Svensson, who is a nanophysicist. He's really he can go down to the small details and talk about them on the nano level, but he can also go up on the microscopic level and can challenge the clinician and say, well, that's maybe not that smart to do this and that and so on. But least but not least, Michael Kerr, who is the big boss of the whole department or the institute, he has also inspired me along the way here. But also there's Pierre Aagaard, who is here today. We have the honor to have here Abigail Mackey, Peter Schelling, Katja Heinemeyer, Håvard Visnes from Norway, and least but not last, Karen has given me a lot of inspiration along the way. So when we're going to talk about how to manage tendinopathy, well, you can see there's a lot of actual modalities we have access to treat it, this condition. And one of them, which we are going to focus on today, is especially eccentric training, but also a little bit the corticosteroid injection. But you see a bunch of modalities, and you really want to ask yourself, what is the treatment of choice? But maybe this is just reflecting that we really don't know what's going on with tendinopathy as such. So, but I will cover these different modalities, especially tomorrow. So back in the late 90s, we had what I would say a paradigm shift in order to treat tendinopathy. And that was really the study of Håkon Alfredsson, who he published this paper in the American Journal of Sports Medicine, and that changed the way we were sort of treating our patients, because with that, that became sort of for many the way how to do it. But one of the reasons for he sort of invented this, or actually he reinvented the idea of treating Achilles tendinopathy, from the early studies of Kervin and Stanish, which also kind of used the same way to treat it with sort of eccentric training. But I think one of the reasons for it came along was actually that he and his group and many or some others was not able to find any kind of inflammatory cells in the tendon, and it is still debatable how much you actually can find. There are some that claim there might be some inflammation perhaps in the beginning, but it actually did that you had this, I would say, pain was accepted during training, and at the same time you could run, well, that did that it was much easier to treat our patient at that time, because earlier you wanted to, you should avoid pain, take care, you're not allowed to run, and yeah, there was a hell of a kind to treat these patients. But now you could just go along with pain, and then actually made them better. All of them in this study actually became better. But the problem with this study was that it was not an RCT, so with all these problems that are there and bias. However, then some years later, so sort of acknowledge or confirm that there was something about it in a more mechanistic way. Henning Langberg, which many of you know, who was also coming from our lab at the time, he did this study on lead soccer players, and what he could show, besides also that he could decrease the pain over the time of 12 weeks, there he could also show that you could actually increase the collagen synthesis. In that way you could actually sort of rebuild the tendon. And with that, and also many other studies, and here's a systematic review on patellar tendinopathy, actually could demonstrate that eccentric exercises is much better than most non-loading therapies or wait and see policy. So that took together that here's really something which is much more potent than any other of the modalities we got. But one of the questions our lab or we had among our colleagues was actually, is it the eccentric loading the treatment of choice, or is it just the loading per se that actually do it? And there was later some systematic reviews by Peter Malnias, and Henning Langberg was the senior author of this paper, actually coming up with this little clinical or mechanistic evidence for isolating the eccentric component. And another very good systematic review by Vasily Shevsky, I don't think I can say it correctly, but they also came with more or less the same conclusion. So if we go in and look more and see on a mechanistic level, when we talk about the tendon and what happens when we load it eccentric, or that would mean if you do a eccentric muscular contraction versus a concentric muscular contractions. Then the group of Hazel Screen from London, they looked at it, and where they actually made these healthy volunteers having an ultrasound behind their Achilles tendon or MTJ junction. And what you can see here is that the slope for either it's concentric or eccentric, it's obviously the same. So it's stretching for the same force. So there's nothing different between the two different contractions. So you couldn't really regard the tendon as just an elastic band. It cannot discriminate between the different contractions. So like this. So to sort of also go more into how much it really matters with the eccentric contraction, or I would say it doesn't really matter that it is eccentric. Then there was this paper where they looked at rats and how where they can contract their muscle, and you can see here if they have the same force level, it doesn't really, there's nothing specific about the eccentric contraction per se, you would say, in order to obtain a higher collagen expression. And there we could also look at this study by Katja Heinemeyer, who also had some rats where they were trained, and then you could see if they train with the eccentric level, they come up to some higher force level. But when you look at the collagen expression, there's nothing of a difference from the eccentric group in these rats who are training eccentrically compared to the other kind of contraction modes, concentric or isometric contraction. So with that, you could say that the tendon itself, it cannot really discriminate. I would say that the tendon cells cannot discriminate whether it's eccentric or concentric contraction. The tenocytes, they just feel the tension. And I think that is a very important measure. In order to sort of have kind of a collagen synthesis and to produce collagen, you want tension in in the tendon, and it seems that the duration of the tension is very important in order to activate the collagen synthesis. But on the other hand, if there's no tension, like if, for instance, that the tenocytes or the fibroblasts who are lying in between the fibrils, they feel and sense all the time what's going on with the fibrils over here, or between the spaghettis, we could also call the small fibers here. Then if there's some kind of a rupture, then they will very fast, very quickly, they will degrade to some extent. And that could explain why you have this very vicious cycle with tendinopathy in the end, and you have the angiogenesis and neurogenic proliferation. So if we look at more at the human level to sort of confirm, or what might sort of address the importance of the loading, you could see that this is a study from the Berlin group by Patis, and they have sort of looked into the influence of high load, where you can see if you do the high loading, there's a 90% MVC where they did that over 14 weeks compared to a group who did just 55% of MVC, then you can actually observe that there is an increase of the cross-sectional area of the tendon, which is kind of very important in order to reduce the stress on the tendon. And here you also see that the time they were loading was around 3 seconds, and then unloading was around 3 seconds. Unloading was 3 seconds. And they have gone further actually by, recently they published a study where they actually tried to see if you have more time under tension, like more than, I think it was around 10 to 12 seconds, that actually didn't seem to do the thing. So you can actually stay with the 3 to 4 seconds in order to obtain these morphological changes on the tendon level. So about in the same year, in another tendon, the patellar tendon, Mads Kongsgaard, he who was a former postdoc of ours, he actually, well, it was actually the first study to show that you could actually, by resistance training, could increase the cross-sectional area of the patellar tendon, especially in the proximal and in the distal area, and but nothing really at the mid portion. And that was quite an interesting study because the one leg was actually doing 70% of 1 RM, and that's where the data you see here. Oops. Can you see what's on the, yeah, you can see it, okay. But the other leg was doing a 15% 1RM. But interestingly, the one who was doing the 50. Hello? Yeah, that's good. Okay, sorry. In that study, which was kind of interesting, that it was definitely the high load leg who actually increased the cross-sectional area of the patellar tendon in the proximal and distal part. And after 12 weeks of resistance training, but actually in the 15% 1 IRM, it was there was actually also an increase of around 5% in the proximal part, which means that you can actually go quite some lower and still have a little increase. But definitely the high load was doing the thing mostly here, and other had also confirmed this. These findings, Olivier Senes from Marco Narici's group in England had also confirmed this. So then there was this Danish study also came, it was published in 2013 from Aarhus, from Christian Wissing's group, and he could actually, he actually had a group of volunteers where the one leg was training eccentrically and the other leg was training concentrically. And interesting is there was no difference between the two legs. However, it's just to say that they gave them also whey protein, and that seems to do some kind of increase, interestingly, in both legs. So when we talk about the tendinopathy as such, is there really any kind of studies who has tried to control or has made the comparison between concentric and eccentric contractions? There's really not much out there. However, some have done an effort. And again, the group of Alfredsson from Umeå in northern Sweden, some years ago, back in 2001, had this study where one group were doing the eccentric training and the other group concentric training. And to no surprise, they came out that the eccentric group was much more superior in clinical effects. But if you look at the different exercises done in the eccentric training group, the load was much higher compared to the concentric training. So no doubt, there was no surprise that it came out differently, but how you actually ask the question how good of a job they did to control for the loading. Yes, so we, or our group by Mads Kongsgaard, actually tried to sort of challenge the whole paradigm about eccentric training. However, this was not a loading controlled study as such, but it was more a study where sort of challenging the paradigm around eccentric training, but also the giving corticosteroids, which is given quite often by doctors. And so therefore this study was performed where you had these 3 groups, where the cortisone group were giving 2 times corticosteroid injection with 4 weeks between them. And then we had the classical eccentric regime where they performed eccentric exercises twice a day, 3 times 15 unilateral eccentric squats on a decline. And then they could load progressively when they didn't feel any pain. So they were allowed to feel some kind of pain, and when they did not feel pain anymore, they were loading more in a backpack or so. But then the third group was the heavy slow resistance group, and then they were training 3 times per week, performing classical exercises like leg press, squat, and hack squat. and beginning with a 15 RM, and then they were progressing down to 6 RM over 6 to 8 weeks, and they were with 3 sets. But the last and important thing also was, of course, they were doing what we could call slow movements. 3 seconds concentrically and 3 seconds eccentrically. And they were also allowed to have some kind of pain during the exercise. So what this study actually showed was that for the VISA score for the VISA score for the patellar tendon, all the 3 groups actually improved after the 12 weeks. But interestingly, after the follow-up of 6 months, you can see actually the group who got the cortisone actually went worse, which sort of confirmed what we also see to some degree in other studies, particularly in the elbow. But the pain, of course, did also go down for the 3 groups, and again, they actually got worse for the cortisone group. And then we also saw that in the for the ultrasound measurements before and after, the Doppler activity went down and the thickness went down, showing that the tendon as such actually was getting better and getting at a more normalized condition. So, with regards to the satisfaction about the treatment, then there was quite some satisfaction after 12 weeks for the cortisone group, but also for the heavy slow resistance group, but not for the eccentric group. No, that was not really a big surprise as such. However, at the 6 months follow-up, it certainly changed for the cortisone group, but the eccentric group stayed the same. But actually, the heavy slow resistance group stayed at the same level, or perhaps a little better, from the 12 weeks time point, which was kind of good. There was also taken biopsies in this study, and that was also very interesting, because what you can see here for the heavy slow resistance group for the collagen content, that actually increased after the 3 months, but nothing for the eccentric group. And you can speculate why that is so, but I'll come back to that in a while. But then you can see for the cortisone group, it almost went the other way around. It was minus 16%. And as a little an interesting thing also from an aging perspective, the marker of the built-in of sugar cross-link pendositine, this biomarker, actually went down for more than from around 23%, showing that you had a rejuvenation, or you got actually a younger tendon by doing a resistance type of training. So actually you also have hope to get younger in your tissue by doing resistance training. So with the conclusion about this study, that you can definitely say the cortisone was good on short term, but on the long term it was not that good of a thing. It actually went bad. But it seems that the heavy slow resistance training actually is doing the job both on short and long term, which was kind of very nice. But why was it so that the eccentric group did not perform that good compared to the other or to the heavy slow resistance group? That we could look a little more into, because if we look at more biomechanically, then we can say that if you're doing a decline squat, then that seems to have a better result, because you are putting more load on the tendon. And this is shown by, again, Mads Kongsgaard, and Per was also involved in that study, where you can see if you have the decline, if you are a lax tendon, it's here, but on a standard squat, then the tendon, here's the patella and here's the patellar tendon. But if you're doing the decline squat, then there's much more strain on the tendon. which means that you got more load and perhaps thereby you get some better effects. And there's a biomechanical explanation for that. But if you think about this figure also, which shows that the EMG activity for the knee extensor peak EMG, then the decline squat actually involves a lot of EMG activity and thereby also a lot of effort for the one to do it, because you come up around 70% of 1 MVC in each time you go down, which is quite tough. And then think about that you are doing this 3 times 15 repetitions, and you do it twice a day. That's quite an effort, I would say, and quite tough. So by that, I would say, and having this figure you have seen earlier in Karen's talk, that if you think about that the tendon turnover is quite slow, it takes around 36 hours or more in order to obtain a turnover. And then you have the eccentric group doing this kind of loading many times a day, every day. Then you don't really respect the recovery of the tendon. It's just you're poking the tendon every day, and you don't get the super compensation you want, really. So that perhaps could explain why you didn't see an increase in the collagen content, for example. So how is it about other tendons, like, for example, the Achilles tendon? We have also looked into to that with the same approach, where the Alfredson regime from the late 90s also was challenged with the same heavy, slow resistance type of approach 3 times per week, doing leg press, squat, and hack squat, and with the same progression and doing slow movements. And what that actually shows that if you have the 2 groups at baseline here, this is for VAS running, then after the 12 weeks, both groups again go down in pain, and that seems also to be the case after 1 year. However, then again, both groups actually go in the direction where you have less Doppler activity at 12 weeks, and again, there's more less activity of Doppler and less thickness of the tendon. And I forgot to say that in the other study, that was not really the case for the eccentric group, but it actually turns out to be the same here in this study. So what could you say about this study? Well, it seems that you actually can, by doing heavy slow resistance, that's only 3 times a week, because when you're doing the Alfredson regime, then it is every day. So you can actually obtain the same results but by doing less, which I think is quite important. And the compliance in this study for this group was also much higher. So other areas of the body that's been looked into with the heavy slow resistance type of training was by Michael Ratliff, and I'm sure that we will hear much more about that tomorrow by Michael, where he actually shows that the high loading group over a time here actually could do a better effect than just doing stretching and compared to strength training. But Michael, I'm sure you will tell us much more about that study tomorrow. So just to say, to sum up on the loading before I go on a little more about, I would say, the prevention part, then we could say that the heavy slow, the tendon doesn't care about what kind of contraction mode muscular contraction mode you do. It more needs the magnitude of tension or load, and the duration is important. And you need some kind of pain when you train it in order to load it properly. But the second thing which is important is also that you have to do it every other day to respect the turnover of the tendon. And most studies shows that you have to do it to get consistent results. You have to do it at least 8 weeks. And least but not last, it was 75% who were good responders. So there's still 25% who didn't really have the good response of this type of regimen or heavy slow resistance type of training. So we still need to know more how to treat them. Yes, so I would go on and just say a couple of words that when we do heavy slow resistance training or heavy loading, then it turns out, like Karen already mentioned, that the tissue down, if you have an insertion problem, it doesn't seem to respond as well. And the reason for that is that because at the insertion is that we have some other types of tissue, more cartilage tissue, which is even more slow in the turnover. So that could be one of the reasons for that we don't see as good as a result, or things takes more time in order to get better. So the other situation that Karen also have mentioned is that you have to keep in mind, if you are dealing with elite athletes who are having a tendinopathy, well, is it a good idea? Here you can see from the business study to perform exercises during the time where they actually are having a problem and doing their sports. I don't think that is a good idea, because you see that for the visa score you're actually going down, even though there was not significant, but it was almost there. I think there was more a power problem here in this study. So you really should think about that. But I think Karen was one of them, one of the first actually to demonstrate in her study that she just showed that by using the pain monitoring model, you can actually give the athlete a tool in order to sort of come around, not to have too much loading or too much pain. So with that, she actually showed that there was no differences between a group who actually were training or running, jumping at the same time they were doing their rehab. So I think that is very important, that you can actually run or do some of the activity they are used to. So that would mean that the compliance for the person who are doing the rehab is much better. So that is a good idea to have this tool in your hand as a therapist, and especially for the patient. So to say that we might also have other tools to sort of control for the load, and by showing this figure, which most of you actually are familiar with, that the figure that actually is just a little more simplified from the Karen's Ledbetter, or there was actually by Ledbetter, coming from Ledbetter, that the thing you have this iceberg kind of issue. So that here you see that the athlete would slowly accumulate pathology and then cover up and then get their pain after passing the pain threshold. And by that you can actually use, before you come into these trouble, then you can have the ultrasound. And there was a study some years ago who wanted to sort of, or took that idea up, that that could be used as a sort of a prevention tool in order to run into troubles here. And that was by Ulrik Frederiksberg, also from Denmark or from Jutland, where he actually in the best league took soccer league. He took a group of soccer players and followed them from the beginning of January and to the end season to the December, and ultrasound scanned their Achilles and also the patella tendon. And what he actually could show, that those tendons who were asymptomatic from the beginning but had changes, they had a 45% higher of a risk of getting symptoms by the end of the season. So if they had this thickening, then there were much higher of a chance of getting problems. So then he took this up and said, well, we could actually perhaps do something about it and perhaps make some prevention of those who actually have these changes. And he did this study, which I think perhaps many of you know, that he had, again, from the Danish Super League, the best league, where they were randomized these soccer players, elite soccer players. One group was doing stretching and eccentric training for 10 minutes, and there was a little more than 2 times per week. And what it actually showed was that in the group of those who had abnormal ultrasound changes from the beginning, it turned out they actually increased the injury risk. So that would mean that if you were doing this kind of program, you actually ran into an injury. Although those who were normal from the beginning seemed to have less of a risk of getting ultrasound changes by the end of this follow-up after the season. So that means that there is some kind of you cannot just put more on a tendon who has already been poked or have changes. That would be a bad idea. So maybe we should rethink our way of doing when we do exercises. And we, as a therapist, for many times we do want to give them exercises. But Karen mentioned it, and Michael Ratleff also mentioned it yesterday. Perhaps it's an idea that we should more go into the detail of if we have our players that as having some kind of symptoms, maybe we should go more into that and hear what they actually say. Because the problem with tendinopathy is that what you know is it's a sneaky problem. In the beginning, you feel some kind of perhaps changes, stiffness in the morning, perhaps a little pain, but you don't. When you then run, you warm it up, and then it's all gone, and you are happy, of course. But when you continue your activity, as I showed you with the figure before, you are perhaps on the decline because you are doing wrong in your training. You have the training error, and then you are going down this. I would say Stanish and Kervin described. There's a continuum of where you have a mild condition, and you are not. The performance is not affected. But then you have a moderate problem. It starts with activity and lasts for 2 hours and more. And then performance slightly get a little affected. But when you really have a severe problem, then you're there. Then you really are stuck. And then you can just, perhaps by doing unloading, you can come out of it. Then you have to do the rehab. But I think up here at the top, and Karen also came into there, you can do the job and listen to your players, and when they start to say, okay, then now I have some kind of thing going on. And I think it's important, especially when you're dealing with young talents and in the clubs, that you should have some kind of education, like Michael Ratleff was saying yesterday, and also Karen emphasized that they should speak to the trainer, the coach, or the therapist, if there's someone there, then to say, okay, perhaps we should do something about it. And then you can do your load management and perhaps some exercise intervention. So there you have, of course, all the typical parameters who can increase the load, perhaps find out where is the problem that actually are doing it, and then you will unload the tendon. Because just to remember that when we are doing kind of jumping or running, you are coming up to where we are just under the limit for what the tendon can withstand. And like for just sprinting, it's almost 9,000 Newton. And if you think about a tendon is around, or typical tendon is 1 square meter, and for like the Achilles tendon, you are very close to the limitation. If that could, or in a good athlete, it might be bigger, but some might be thinner and then you are already past it, and you have a kind of rupture or starting your problem and going down the hill. So I think the whole idea, restitution, listening to the body, as both Michael and Karen have said, and I'm emphasizing, would be a good idea, and take unloading before you put on just your exercise on top of something would be a good idea. So that we had for some years ago did this, I would say, model. So when you are dealing with tendinopathy, you have to diagnose, you have to make sure they actually have tendinopathy. Many times they have perhaps other problems, and you have the whole issue of acknowledgement that you're actually having a serious problem when you really have a real true tendinopathy. Many people or many persons doesn't acknowledge they're really having a problem, and the whole thing that they should take it serious. But also here, or again, then you can go in and try to look into the load management issue like I talked about before, and then you give them the advice how to unload before you actually go into the loaded regimen. That I think is very important. So and then we can come into the whole aspect of doing passive treatment or alternative treatment. If they go above a VAS score of 3, you might use some these modalities, but I'll come much more into that tomorrow, how you can use it, and maybe might be a good adjunct to exercise. There are some studies showing that there might be some something to get by using, for example, shockwave or laser therapy might actually make you come faster to the milestone of getting back to sport. And then so then Karen had already touched upon the return to sport issue. I want to go more into that. So the last thing I'm going to say here, this long talk, is that you have to, in this part, think about what type of tendinopathy you have. If it's in surgical, you have to respect that it takes time. You can, and heavy slow resistance training or loading might not be as good in this condition. And you should also think what kind of loading the therapy or the sport or the athlete is undergoing before you just put on some loading. That's important. And do the individual load management. And perhaps we can do something about some of the passive modalities, but I will let you know much more tomorrow about if it's a good idea to give NSAIDs or painkillers or injection therapy in order to kill the pain and make them better. Perhaps there is some other choices you can do, but I'll cover that tomorrow. So thank you for that. Yeah.
Do you have any questions?
Stefan?
Yeah, first of all, thank you for your talk.
Thank you.
Maybe my answer I will get tomorrow in your speak, but when we look to the collagen turnover, we know, for example, vitamin C had a big influence on collagen synthesis. Is nutrition a way to solve the problem?
Yeah, I think there's some potential. And in our workshop where you participated, I covered some of it that perhaps, and also in the talk of Kevin Tipton, that maybe if we eat some type of food that might actually do it worse. So for instance, a person or athlete who are eating a lot of processed food, for example, might be a bad idea, because then the whole milieu environment around the tendon is filled up with sugar, which might do some bad things for the tendon, like cross-linking. There's quite some data now showing that. So that could be something, but it could also be the other way around, that you actually can eat some good food and then in that way accelerate in a good way the recovery. Yeah, that's Kevin.
There's not a great deal of evidence for nutrition and tendons. Tendons don't seem to respond to protein like muscle and bone protein does. So tendon protein doesn't seem to respond as well. Vitamin C maybe, but Keith Barr has some new data out about gelatin.
That's true. Yeah.
I would argue it's very preliminary, and he makes too much out of it, but it's at least a start and maybe something to explore further. So there could be something there.
Yeah.
But I'm still not sold.
Convinced. Yeah, I agree. That's true. That by eating collagen, it might seem to have a good affection of the tendon, but we have to have more data on that. But just in the line of Kevin saying earlier in his talk that for example, we in the study of where we took some mice, some of them had high-fat diet and some of them just ate that chow. And we were measuring them on these advanced glycation end products. It turned out after 4 weeks, 40 weeks, that the concentration of these advanced glycation end products was much higher in the chow group. And maybe the reason for that is that the chow itself is highly processed, high heated, and that induces these advanced glycation end products into the food. And there's actual data to show that might have some chance to build in the tissue. So that could be, and that was also to show that the tendon actually got stiffer by that. So if that is a good or bad thing in order to maintain health, I think there's certainly data to show that advanced glycation in products is upregulated in diabetics. So I think that is a bad thing, and I think with that, processed food is a very bad idea to eat along the way, and especially perhaps in a rehab situation. Yeah. Other questions? I think we are quite tired now. You're tired. Oh, Kevin?
So I just want to know where you were 15 years ago when I had my insertional tendinopathy and had all those problems with none of this kind of information. Yeah. So it seems that y'all have been making a great deal of good progress, even acknowledging that there's still a lot of questions to be answered. I was going to just add to what you said about nutrition, about the diet, and it's sort of what we were talking about during the break, which is a lot of times maybe we make too much out of all these details, like whether or not we're going to eat gelatin to support your tendon, when really it's just about almost common sense. Don't eat too much processed food, don't eat too much, eat a good, your grandmother was right, eat a balanced diet, with lots of fruits and vegetables, and then you get your vitamin C and you get your other things. So sometimes I do think that we try to look for too many little tiny details, and it's the forest for the trees kind of thing. We miss the forest because we're looking at the leaves on the trees. So I think I support completely what you were saying earlier about, limit your processed food, and don't, have a beer but not 5 or, something like that.
Yeah. But I can tell you that there's some nice data from a group in Cleveland showing that, again, we can debate the whole idea of doing science on rodents and how you can translate that into humans. But nevertheless, actually, the group who is looking very much on these advanced glycation end products, which seems to have an affection on aging, they showed that by doing calorie restriction, they made the tendons, or the tail tendon, was a kind of a systemic model of how old you are in your connective tissue, they could actually show that you actually reduce the amount of these advanced glycation impulse by calorie restriction. And then another group in Mount Sinai in New York, where they did where they sort of control for the energy consumption, but they had less of these advanced glycation inputs in one group, but still both groups had the same energy intake. And that could actually show that they had less of I think it was not tail tendon they looked into, but that's some kind of other collagen tissue, which I can't remember. They could show there was less of these advanced glycation inputs. So there might be, if you will believe in these data, that could show that there might be a good idea not to eat processed food.
All right. Just to keep in mind that the recent analysis came out showing that only about 30% of rodent data can translate to humans.
Yes,
and
I agree.
18 to 20% of it is completely the opposite message.
Yeah,
so
yeah, I
think caution is definitely the word there. But and for calorie restriction, I think it's even more because it might be an academic argument to say you need to restrict calories, but to tell people that they're going to have to stick with 80% of their calories all the time and they're going to be miserable, I think it's not going to work. Also, they're going to have problems with their muscle.
Yeah.
So
I agree. And get depressed also.
Be cranky.
Yeah. Okay. Thank you very much.